Dr. Rawat is going to speak on lab D2 subtotal gastrectomy. Dr. Saumitra Rawat, please.
Thank you very much for inviting me, and my talk has been made simpler by Dr. Sahu, and I bring warm greeting from Sir Gangaram Hospital. This is my other affiliation. I was an honorary consultant in Christie's. I'm a program director of their international fellowship program. Other affiliation is Royal College of Surgeons, where I'm a laparoscopic trainer and member court of examiner. So I'm just going to quickly go through, for the benefit of our junior consultants here, what does NCC guideline tells us that D2 dissection acknowledged by the NCCN, and these are the lymph node you need to take care of. This is, let me just see. I think this is, pointer is, so you got a right paracardial, left paracardial, then the station 3 lymph node on the lesser curve. On the greater curve is 4S, short gastric, left gastroepiploic is 4SB, 4D is right gastroepiploic, then you got a 5, which is 5 is suprapyloric, infrapyloric, left gastric, common hepatic, celiac, and then you got a splenic hilar lymph node. This is a splenic artery, is station 11, distal, proximal, and then 12 is a hepatoduodenal ligament. So I will go step by step. I've done my video presentation on step by step. So this is what it is. I'll take it one by one. This is the port position I normally use, 12. I normally put 12 here also, 12 and 5 here. I use Nathanson. I don't use the fan liver retractor. So the first step is division of gastrocolic omentum. What I would do is, I will show the simulation first, and then I'll show the video step by step. So this is what you do. You cut through the gastrocolic omentum, 3 centimeter from your gastroepiploic vessels. You go and divide the left gastroepiploic artery, and you take out 4SB and 4D lymph node. And this is what it is. Gastrocolic omentum, you go up towards the spleen there, and it's 3 centimeter away from the stomach. You find out the left gastroepiploic vessel, which is at the inferior, comes out there at the inferior pole of the spleen, and you divide it. So you have taken care of those lymph nodes. The second one is the infrapyloric lymphadenectomy. You go towards the pylorus, divide the right gastroepiploic artery, take the lymph node station number 6 en bloc. And this is a simulation of it. You go down towards the pylorus, go to the neck of the pancreas. This is a right gastroepiploic vein draining into the loop of Henle there. So you divide the vein first over the neck of the pancreas, then you go to the right gastroepiploic artery, divide at the origin, which is coming from gastroduodenal artery, and you sweep all the lymph nodes along with it. So this is what it's showing. You are coming down, going towards the pylorus, and retracting the stomach up. And what you need to do is identify the right gastroepiploic vein. Sometime when you have a tumor posteriorly, it's difficult to, when it's all stuck together, differentiating between the right gastroepiploic vessel and the middle colic vessel. Middle colic artery and vein are together, right gastroepiploic vein and artery, they are separate. So vein has been divided there, separating it from the pancreas, the upper border of the pancreas here. So once your stomach is up there, then you try to find out the right gastroepiploic artery there, and you take whole of station 6 lymph node along with it. So that's your right gastroepiploic artery. You are dissecting it free again from the superior border of the pancreas. That's the right gastroepiploic artery. As you see, whole of your station 6 lymph node are here up. So this is fully skeletonized, your right gastroepiploic artery, and you just divide it. And then comes the suprapyloric lymphadenopectomy. You divide the right gastric artery and take the suprapyloric lymph node, that is lymph node station number 5. And that's the simulation. In the simulation, they divide the pylorus first, but I dissect the artery first, clip it, and then I do the pyloric transection. Because if you don't divide the vessel first, you won't find the space. So this is what it is. Yeah. So this is a suprapyloric one. So you are taking the station 5 lymph node, you are going there and going towards identifying the right gastric artery. That's where you have found the right gastric artery. Coming from the common hepatic artery, you divide the right gastric artery at its origin, putting a clip, and as you could see, that's the station 5 lymph node which will be swept, and that's you fire the stapler. So I use a linear stapler, blue. And then you go to the hepatic and splenic lymphadenectomy. That is where you identify the left gastric vein, which is draining directly into the portal vein. So this is the most difficult part. Suppose if you have a bleeding from left gastric vein, that could be very significant. And that's the left gastric artery coming from the celiac trunk. And that's what is showing. As you could see, that that's the common hepatic artery which is bare there, and gastrohepatic ligament is clear. That's the bare of the common hepatic artery here. That's the splenic artery on the other side. So that's the celiac lymph node. We are taking it off. So we are taking it out from the base, and that's the splenic artery. So this is a station 11P lymph node, which is a proximal, and that's the celiac big chunk of a lymph node there. So that's the common hepatic there, that's the splenic. You lift it up, give a traction from your left hand, and you just keep on taking whole of the lymph node chunk with it. So this is again the common hepatic. And as you could see, the celiac lymph node is lifted up. Now, the aim should be try to find the left gastric vein first, not the artery, because if you clip and then give a traction to the left gastric vein levels. So this is the fascia on the vessel which I'm pressing so that I'll take out all the fascia. You can see the lymphatics also there. So lymphatics is also coming with it. And this is a gastrohepatic ligament which I am just clearing it there. And you could see that's the left gastric vein which is coming into the view. So once you have dissected the lateral part of your common hepatic artery, you are sweeping so that everything come en bloc. If you could see, that's the lymph node, that's the station 7 lymph node over the left gastric vessel. So this is a left gastric vessel, you could see it clearly there. So you are making a space so that you can clearly visualize, dissect, and when you are finding the left gastric vein, very careful about the left gastric vein. So you could see that's the portal vein there, that's where it's draining. So you divide the left gastric vein, and when you go there on that side, you are keeping it close to your main vessels, and you could start seeing the right crus of the diaphragm there. Keep on going there, and you pull it up, lift it up, and then you would see your left gastric artery appearing there. But when you are doing the left gastric artery dissection, go slightly higher up, so that's the right crus of the diaphragm, so you go higher up so that the left gastric artery is fully visualized there. So you have clipped the left gastric artery there. And the next one is right pericardial lymph node, that's the station 1 lymph node. You sweep all the station 1 lymph node down so that your lesser curve is bare. This is what is it in the end you could see, and that's the anastomosis for the subtotal gastrectomy. You have fired the linear stapler there, creating a hole in the posterior part of the stomach, putting a linear stapler there, and closing the hole. I use a single PDS, and because you are doing a stapler, it doesn't take much time. So this is a circular one. I will just leave it. This is what comes out. The specimen which comes out is the same, whether it's open or laparoscopic surgery, but this is a scar of open surgery, and this is a scar of laparoscopic surgery. So sometime I put a camera through here, quite a few times I put a camera through here, so that when you are firing a stapler, you are going straight up, so that there is no turning and twisting. And when you are doing a infrapyloric and suprapyloric, so put a camera through here, you can do it from these two ports. These are the principle of surgery. You need to have a adequate resection margin, 5 centimeter proximal, 2 centimeter distal, radical lymphadenectomy. As I've said, all the stations should come out, and you should have at least 12 lymph nodes. No, sorry, 16 lymph nodes. It's a teamwork. This is our team in Gangaram. These are the 4 pillars of surgical standard. If you don't know your steps and the sub-steps, that's the reason I have mentioned the steps and the sub-steps, then, if you go on doing a major gastrectomy laparoscopically, catastrophe can help. And it's a learning. This is my training, which I started in 2001, did a advanced laparoscopic training in Limit in Leeds, and then went to Strasbourg, did a surgical master class, and then did a D2 gastrectomy course in 2006, and then I became a training trainer, and that's what it is. Thank you very much.
Excellent. It's not a presentation. It's an excellent teaching slide, I'm sure. And whole audience enjoyed a lot.
Thank you very much.
And particularly the chairpersons also enjoyed.
Thank you very much.
I think it's the time for discussions. I think a lot of questions may be asked, but please restrict it to the time. Thank you. If there is any question, please. And if there is no question, then we can move on to the next program.
Yeah.
DJ is loop or no?
I always do loop.
Efferent limb, making a loop towards greater curvature, efferent limb going to better or towards lesser?
See, it's entirely your choice, what you are used to of it. It doesn't make any problem, but as long as it's setting up nicely.
Dr. Jagdish has come? Is there? Okay. Fine. Thank you. Thank you, Dr. Rawat.
It does matter if you are doing a total gastrectomy. I keep the blind end on the left-hand side. Blind end on the left-hand side. So that when you are firing a linear stapler, because I do a circular stapler, So when I am using a circular stapler, I go from the left-hand side. So where I have given an incision for the circular stapler, then I go proximal to it, and then, you know, I put a linear stapler there. For the total gastrectomy, I always put it on the blind loop goes on the left-hand side of the patient.